Answer. So, Dr. Kumar would be talking about biometry to some extent and IOL mishaps, how he has managed them. So, over to Dr. Kumar. He doesn't need any introduction. He's from Mumbai, the second generation into ophthalmology, has presented all across the world in all forums at all levels. Over to Dr. Kumar.
Hello. Yeah. Good afternoon, everybody, and thank you, Dr. Rohit Prakash, for allowing me to participate in your course. Now, as you all heard, that it's video interactive, and my topic is biometry. So that itself puts it off. But I will show some part of biometry, what it is crucial, and what we are doing in our setup now. And then I'll show some mishaps in IOL. So we all understand that today modern cataract surgery is 2020 and beyond, because our patients have made it. All cataract surgeries are now refractive surgeries. They are no longer pure cataract surgeries. So on average, what they have seen statistically, that 78% of patients are plus or minus half ophthalmologists, 6% of surgeons get 84% or better, and 1% of surgeon gets 92% or better. So you can rate yourself in your post-op results as to where you really stand if you're checking 6/6 and not 6/9. But when it comes to short eyes and long eyes, the big problem begins. In normal cases, we are in 95% as far as biometry is concerned. So there are two important things, biometry and formula. IOL calculation, the maximum error comes from corneal keratometry, which is 27%, IOL misalignment 14%, IOL tilt 11%, and angle kappa 7%. So now you need to address each part of this as to how you can avoid it. So there's no doubt that contact biometry should be banned. If you want to do biometry ultrasound, always do immersion and do not do contact, and that will remove half your problems. And of course, intraop aberrometry is no longer available now, but optical biometry is what we should technically do for our patients. Of course, the cost goes up, we have all the other headaches, but no doubt that your results will drastically improve. We have lots of machines for optical biometry. You have IOL Master, you have A-Scan, Pentacamel, Aladdin, Galili, so many things. But I went ahead, you can see the whole scan. I had a Nidec AL scan. I've also used the Zimmer G6. I've also used the IOL Master. But ultimately what I bought was the Anterion. So it's the all-in-one figure which does everything. So when you come to biometry, you can look here that you can compare two eyes together. You get corneal aberrations in one shot, and you get your white to white in one shot. So you have information of both eyes that is coming parallel at the same time. So that's one big advantage. And you can also get your corneal wavefront at the same time, so you can know if there are any aberrations. At the same time, you see parameters like IOL calculation, corneal map, angle kappa. All this information is coming through one shot, through one information. So you really don't need to search through different instruments, and that's the one big advantage that you have. And of course, it has a Barrett built-in suite, and now we all know that we are using the Barrett 2 universal, and you can put multiple formulas here. So you can see I put an SRK2, Barrett, and you can put whatever you want. You have 4 options, and 4 calculations will pop up at the same time. So what important information I'm getting here through one instrument is corneal wavefront, astigmatism. It's calculating total corneal power. So that's another big advantage. So if you have an optical biometer which doesn't do total corneal power, do not look at it. You need total corneal power, because some of us have been doing LASIK since 1999. All those patients are developing a cataract, so you will have to look at it. Coming to formula and which one of them is good, you have lots of options. But we all know that if you look at the last one, which is Barrett, it does axial length, K reading, ACD, white to white, and lens thickness. So suddenly lens thickness and ACD is very, very important besides axial length and keratometry, because that actually will determine where your IOL is really going to sit. And this comes a problem when it comes to small eyes or long eyes. And this is just one example of how you can see anterior segment division of large, small, and medium compared to axial length, and you can classify them accordingly. But when it comes to long eyes, you can get an error. But when it comes to short eyes, you get a sudden surprise myopia, because you have a shallow anterior chamber. So some of you can do this. I've suddenly started doing this study that post-op I'm doing axial length measurement, and your lens is actually sitting 2 millimeters ahead, and that's the reason why sometimes even the Barrett formula does not work perfectly. Now coming to new generation formulas, you can see here the Barrett 2 covers everything, short, normal and long, and you can have Hoffer Q for short eyes. So if you have a very high hyperopia, prefer Hoffer Q, otherwise do the Barrett 2. Just one example of an anterior chamber which is very, very shallow, hyperopic LASIK done. So you can see the anterior chamber is 1.92, lens thickness is 4.37, white to white is small. We did multiple measurements. So I also do the Barrett, I also do the Hill RBF, which is artificial intelligence, and the conclusion was to put a 31.5 diopter IOL, and we went ahead and did a 31.5 multifocal IOL with a 3.25 ad, and the result was very, very good. Suppose the patient undergone myopic LASIK. So a big advantage here, you don't have to really worry. Again, put in all the data. You can see normal ACD, lens thickness of 4.37, but a long eye because it's a myopic LASIK. Again, I did an SR, I did all the other formulas, the Higgins L and the Barrett 2K, etc. And even the Hill RBF, and the calculation was, so we have three informations. We have from the ACRS formula, the ACRS Anterion, and we have even the IOL master power. So here you can see that IOL master says 22, Anterion says 22. I went ahead and put an Anterion 22 diopter, and what I got was an excellent result. So I went ahead with put a synergy, a PCIOL, and patient did very, very well. So this is just as far as just one example of a small eye, that this is axial length, which is a micro-ophthalmos with axial length of plus 12 diopter, a normal ACD, and PI done for safety, normal posterior capsule, topography done, just to show you white to white, ACD 2.68, and lens thickness normal. But when you look at the axial length, 14.85. So this is a very, very small eye. I went ahead, this was, of course, I've done all the research, and I went ahead, just one video I'll show of a 65 diopter IOL that I put inside. So this is a 65 diopter IOL made. Challenges you all know, we took all the precautions. I did a femto, and you can see that I went ahead, removed the CCC, never allowed the chamber to collapse, did a bimanual IA because a young patient, did a large incision. You need a 3.5, but this is a 65 diopter IOL manufactured. You need a 3.4 millimeter incision, put the lens in the bag, and then dial the lens into the bag. And you'll be surprised the post-op result was minus 1.5 with a 1.75 SIL. Coming to IOL mishaps, this is one of the toughest cases where it's 14 years back. I had only operated this patient. That time, some of you might know, this was a company called Acridic, made 733 and 7372 IOLs. And here if you see, no other sticker was available. So this you can see the lens and you can see an eyes. Now patient was allergic to Tropicacil Plus. So when I dilated him, all he dilated was mid. And you can see the lens sitting there, and there was a YAG opening. Okay, so this was a multifocal IOL, lens is subluxated, and the patient says, I want multifocality. Okay, so this is all we did. So now coming to this surgery, you can see that here the patient's lens is sitting down. When this happens, we don't have much choice. So here under topical anesthesia, what I'm trying to do is put a intracameral epitrate. So pupil dilates, and when the pupil dilates, you can see beautifully the central YAG opening that is done. We put methyl always on the cornea so to prevent regular hydration of the cornea. Once that is done, put triamcinolone acetate into the anterior chamber. Go ahead and do your vitrectomy right in the center. So that all the vitreous that was coming out, just make sure that that is all removed. And that brings your disc, which is a multifocal IOL, into the anterior chamber. Now, whenever you want to explant something like this, it's very, very important that you hold the disc, okay? So you need micro-grasping forceps, and then once you hold the disc from one side, and then you need micro scissors, and you don't need to cut through and through. As you all know, you cut only halfway, and then use the incision as a fulcrum, and like a Pac-Man, you just hold one end and rotate the whole lens out. Now you can see that there are two haptics. One haptic is in the sulcus, one haptic is in the fused anterior posterior capsule complex. So you can see that it is lying there. So this is how I removed the optic, and once that is done, I removed the other haptic which was floating in the sulcus. And now the question is, the patient wants multifocality. Here I'm just seeing if there's any adhesions in the periphery. Luckily there are no adhesions. Went ahead and did anterior vitrectomy. Once this was done, I just fill in again viscoelastics. So now only 3-piece multifocal IOL is the technique that is available in the market today. So one thing we can do is 100% inject this lens into the sulcus, and because my anterior posterior fused capsule is still existing, we have to make sure that this 3-piece multifocal IOL should also not decenter in the future. So what we go ahead and do is that dial the lens into the sulcus, and once that is done, I'm going to optic capture this. So you can see that I'm optic capturing into the fused anterior posterior capsule complex. And this will never allow this lens to decenter in the future. So I still gave patient multifocality and the patient was quite happy. Now this patient is very interesting, no history, came to me with second attack of high IOP, pupillary block, operated elsewhere just 12 days back. Okay. Now the question is, of course, you control the pressure, etc. I don't have more, but I'll just show you what I did. So you can see this. Can anyone say what do you think is happening here? High pressure. You can see this is all the pupil dilates. And patient came to me on the 12th day, second episode of high pressure. Give him medicine, the pressure goes down. Leave it, again the pressure goes up. Anyone can say something from this?
Lens is upside down.
Perfect. So the lens is upside down. So I go ahead and see what the hell is happening. Dilate the pupil with epitrate. Go ahead, put in viscoelastic below the IOL. Again, put in viscoelastic and bring it in the front. So I got the haptic out and got it in the anterior chamber. Okay. And now question is about the other haptic. Got that also into the anterior chamber. And now I put in more viscoelastic below the IOL. Okay. And more viscoelastic above the IOL. And then I flip this IOL in the AC and then put it back into the bag. Okay, so now the IOL is dialed into the bag and this patient, luckily no injury anywhere, did very, very well. And now the second haptic is just dialed into the bag. And actually this solved all the problem and all the episodes were fine, never had any problem. Just a last case, the patient came like this. Now what are you going to do? Questions? Sorry. What is the next? This is all that the pupil dilates. Now what device will you use to dilate this pupil? I'm under topical anesthesia. So what will you do? Anybody from the audience? So you can see a little bit of the IOL. You can see a complex behind. You can see this is all that the pupil really dilates. So will you use a Malugan ring or a B-hex ring? Yes or no? Someone said no. Intracameral, we'll put and see. It won't help much.
Iris hooks.
Perfect. So why iris hooks? Because we need more exposure. So we really need to know what's happening all around. So I go ahead and put iris hooks. I put 3-4 iris hooks. And now that gives me good enough exposure to understand what's really happening in this whole complex. So you can see that the lens is decentered or subluxated. Now the question is, we want to recenter this because it's a 3-piece IOL. It's in the right direction. But how do we center it again so that it doesn't decenter back? So now I'm trying to bring the IOL back into the center, but I want it to be in the optical axis. So now I use a marking, Rexis marking device. So we mark the center, tell the patient to look in the center, and now we need to support this lens. So principally I'm doing the same thing, putting in viscoelastic from behind the IOL, going ahead and doing a small vitrectomy, again that anterior posterior capsule lens complex. So here first time when I did it, it turned out to be a little small. So you need at least a 4 millimeter opening to do a 6 millimeter optic capture. 4.5 will also be sufficient. So here I made a small opening first. I realized that I could not do an optic capture, then enlarged it a little bit to be able to slip in the optic of the IOL easily inside. So now I got one end of the optic of the IOL inside, and then coming to, so you can see that I'm slipping one end of the optic just behind that complex, and then at the same time I'm slipping in the upper end of the optic just behind the complex. So you can see that it's just slipped in, and once that is done, the IOL will always center and remain in the center. Here you can see I'm re-engaging. You can see the whole fisheye appearance. Remove the haptics, and these patients do very well. Thank you all for your attention, and thank you, Dr. Rohitam.